Welcome to the Women's Health Podcast. I'm Anthony Lowe, the physio detective.
And I'm Marika Hart, a pelvic health and musculoskeletal physio. Together we interview leading authorities, we answer questions and share our thoughts to provide the general public with the best quality information that we can find on all aspects of women's health. Please remember that the materials and the content on this podcast are intended as general information only and are for entertainment purposes.
They're not intended to be a substitute for professional medical advice, diagnosis, or treatment. Now, sit back, grab your favourite beverage, or do your own thing, and enjoy the show. Everybody, welcome back to the Women's Health Podcast, and we've got Dr. Tracy Sher with us. Tracy and I, we've been friends for a long time now, and she's amazing. She runs a clinic. She runs the Global Pelvic Health Alliance membership, GFAM. I always think of it because it's like GFAM, Pelvic Guru, Pelvic Global, and, all round conference speaking and education and hosting education courses and running this community, which is fantastic. You do pelvic PT, sex counselor, strength and conditioning specialist, as well as, knowing what you've done in complex pelvic health and in particular pudendal neuralgia. When the topic came up as something that we can talk about, of course I thought of Tracy. Let's get Tracy. So that's what we thought. And we've been working together really well because we share the same mission, which is to get it out there, to share it with people. And that's what me and Marika love. And we're really looking forward to hearing about pudendal neuralgia. So maybe just right off the bat, pudendal neuralgia, I've seen it thrown around as some sort of catch-all diagnosis, but then other people have really specific aspects of it. Can you help us a little bit to understand the pudendal nerve and the diagnosis of it all?
Sure. And actually, there is a tricky way of diagnosing this, and it depends on who's diagnosing it, right? But generally speaking, pudendal neuralgia essentially is neuralgia in the distribution of the pudendal nerve. So I use my hands a lot, so you might see me try to do a lot of demonstrations, which I know as a podcast we can't always see, but there are three branches of the pudendal nerve. Okay, so we have one that is called the inferior rectal, and that goes to the rectal anal area. We have one that's perineal that goes to the perineal branches, the labial area or the scrotal area and that area. Then we also have the dorsal aspect, which goes to the penis or the clitoris. So essentially, if there's pain in the distribution, anywhere in that distribution of the nerves, that's considered pudendal neuralgia. Now, as you can imagine, this can be a tricky diagnosis because there are other nerves in that area. There are also other types of diagnoses and conditions that can happen in that same area. So when someone is diagnosed with pudendal neuralgia, it becomes this sort of thing of it's a label that we have. So many people are happy to finally have a label and a diagnosis. So it's wonderful for them. And others say, well, now what? Or what do I do now? And is that enough just to label them that? Because some people will say, well, now I have a diagnosis. I'm so excited. And it's like, okay, now we really have to figure out, is there anything underlying that's a differential diagnosis? Is this technically your only diagnosis? And then let's go from there and try some things. So it's an entry point. I feel like it's a label and an entry point, but it's definitely not as definitive as other diagnoses in some ways. So this becomes an issue. And then I'm going to add another layer of complexity to this. The terms that get mixed up a lot are pudendal neuralgia and pudendal nerve entrapment. And even in a lot of the research, and if you look at a lot of the literature over years, there's been a conflation of those two terms. So pudendal neuralgia and entrapment are two totally different things. And when I teach my courses, I explain someone with entrapment, so the nerve is entrapped in some way. And again, there's various ways where the nerve could be entrapped. It can be at the nerve roots, closer to S1, 2, 3, or it can be further down in the branches. And if it's entrapped, where it's actually, and this is again, it could be surgical types of entrapment, it could be some sort of tumor, it could be a variety of reasons why it's getting entrapped, could be sometimes scar tissue. So if it is in fact entrapped, someone could have symptoms of pudendal neuralgia. So you can have entrapment with neuralgia symptoms, But if you have pudendal neuralgia, you don't necessarily have entrapment. And there are people walking around thinking for sure they have entrapment. They look online and say, I meet all of these Knott's criteria for entrapment, but actually, in fact, they have a form of neuralgia potentially only. So there's a lot of this conflation of those terms, and people get very concerned. I think I have entrapment, when really, if you look at us, and many of us that talk about this a lot will say that maybe it's only 1 to 2% of those with pudendal symptoms that actually have some form of entrapment. So it becomes just even giving people hope and understanding that there's so much we can do that's conservative, and you likely don't have entrapment. But then there are specific cases we can get into this as well if we have a chance of what we look for when we're considering that there is entrapment.
That's fantastic. I have a million questions, but I'm going to actually bring it back a bit in terms of the nerve itself. So
Yes.
this pudendal nerve has a little bit of a funky little pathway.
Yes.
Could you talk a little bit to that and any differences between male and female in terms of the coursing, or, you know, the areas that it might be more susceptible to having from a, I guess, an entrapment or a neuralgia irritation kind of perspective? So just a little bit about that anatomy and where the nerve goes, that would be great. Thank you.
Yes. Now, usually I have these great diagrams and I'm able to show the whole course. So this is all going to be just me doing some sort of strange hand motion. But in general, so there's 2 sides of the nerves coming out. Okay. So you have, a lot of people don't realize there's actually 2 sides. You have a right side and left sided pudendal. And the other thing to keep in mind that's really important with this is that when you see a pudendal nerve, there's usually pudendal artery and vein, arteries and veins that run with it. So you have basically a neurovascular bundle. So it's taking a course with the arteries and the nerves, arteries and veins at the same time. So you've got this whole bundle going on. And the other thing that's really, and why that becomes important, is when you look at diagnostics, you can't even really see the pudendal nerve. It's that small. What they're looking for actually is the neurovascular bundle where you're seeing the artery and vein, and that's how they can pick up potentially where the pudendal nerve is. So it's quite small, actually. So where it's coming from the spine, and then it goes out the 2 sides, and essentially it goes down into the pelvis. And what's really fascinating about this is it goes through what's called the lesser and greater foramens, and where there's an area called the claw, and that's the sacrotuberous and sacrospinous ligaments. Where those cross, that's one of the biggest junctures in terms of when people say they potentially have entrapment. When they do decompression surgeries, the problem a lot of times is happening at that area of the claw. You can see my hands here. Essentially, if they're too tight, this can be congenital. And this can be also from major injuries. Sometimes you'll see someone that had a major skiing accident or some sort of other traumatic injury, where this is when we look for potentially that claw area, sacrotuberous and sacrospinous, get extremely tight or scar tissue there. And so that's a point where, as it's coming through the foramens near that area of the claw, where they can get tight or be entrapped. Okay, so you've got that coming through. Then it gets really fascinating, because then it's coming through further, it starts to branch off. So this is when you can see different variations in anatomy when you look at the anatomy dissections. In some cases, you'll see that the dorsal aspect and the perineal branch go in through the obturator fascia. So they basically go through the obturator fascia into what's called the Alcock's canal, and then come up through and outside to where you're getting it into the labial area or scrotal type of area, as well as into the penis or through the penis. And again, this is going back into, again, the anterior aspect of the pelvis and into the clitoris or the penis. Okay, so, and again, if you were to look at a chart, there's so many things going on. It affects the sphincters, it affects the tissue, the skin, and in some cases, also you think about levator A9 muscles. So it's a variety of different structures, from muscular to sphincter to sensation. And actually, the pudendal nerve has all of it. It has autonomic, it has sensory, and it has motor. So it has all 3 functions, which is also really important. And the reason I say that is some people say, oh, can't I just cut it if I'm in pain? No, because of the autonomic and motor functions as well. It's not like the genitofemoral or like ilioinguinal or something, where a lot of times they just can do a neurectomy on those. So back to where the anatomy is. So then the last branches off earlier. So when the other 2 potentially go through the obturator fascia, the other one branches down and into the inferior rectal area. So it goes to the anal sphincter and in that area. So it's important to know, and this is why when someone is having pudendal symptoms, it's not enough to just do a test at the Alcock's Canal, because what if the problem is actually deeper? They're feeling it deeper in that claw area. Or what if they're having clitoral symptoms? Or what if they're having penile symptoms? So there's a lot of things to look at. And this is where I think, again, where I could talk for days, and what I love to teach about is the ways to look at each anatomical point to figure out, is there pudendal nerve irritation at any of those points? And so again, I can go into much more detail into what that looks like. So there's specific areas superficially. What we didn't talk about is at the ischial spine. In that part of the deep pelvis, that's another area where you can twang that nerve. And some people think it's a trigger point. They'll get on it internally, vaginally or rectally, and go near that ischial spine and say, oh, wait, they're having a lot of symptoms there. That's actually because you're twanging the nerve. It's not because there's a trigger point there. So there are specific areas where you can do palpation, where you can kind of get a sense that this is the area that they're saying they have their symptoms, and you're able to reproduce them. And it is lining up with where the pudendal nerve would be, in fact. And if you think about it, the pudendal nerve is lying very medial and central. So if someone has a problem where it's more on the inner part of the thigh, or a little bit out, further out, even on the labials and labia area, it may actually be more posterior femoral cutaneous, as opposed to really being midline and genital specifically. Then you're looking more pudendal.
Okay.
With that, I mean, without a diagram, that wasn't too bad, right? Usually I like to, like I said, I use a lot of diagrams, but
I thought it was great. And for those of you who are listening, you can always go to our YouTube channel or our Vimeo channel and find it there, or find it on the website with Tracy doing all her hands. So just to summarize, it S2 to 4, it comes down and through, it branches off 3 ways. It seems to go down. It can get caught in some of the soft tissue structures. It can be palpated in some places, but not all places. It goes down, it comes back up, and it can go down and split off early. There's those 3 branches, like you said. And then but you said midline genital area, but sometimes, it could be a different type of nerve, and it's got the 3 functions, so the autonomic as well as the sensory and the motor branches, which is why you can't just cut the thing, because it's got a job to do. And so I'm pretty sure, is that a good summary so far of the anatomy?
Yeah, that's a fantastic summary. And I feel like this is where, again, I want to highlight something that makes sense now that we've just talked about this. If you think about different fields, so neurology, a lot of times neurologists know a lot about the nerves. They know a lot about spinal nerves, but suddenly when you say pudendal, it's like they just didn't get a lot of training in the pudendal nerve, because it's deep in the pelvis and genitals. So they kind of miss a lot of that training. You go to orthopedic, talk to a lot of orthopedic surgeons. They're like, oh, wow, I know all about the nerves near, labrum. And you think about hips and spine, but again, they don't really study, nor do they have a lot of experience dealing with pudendal nerve. If you go to a gynecologist, they've had a lot of training in general on looking at more systems and organs and for example, uterus and cervix, but not a lot on nerves, because that's not their specialty. So when you really, that's why I realized that as I was going along in my career, no one's really handling this, really looking at the anatomy and really saying, what are these nerves and the pelvic nerves, and what can we do to look at the anatomy and reproduce symptoms and test it and retest it. So that's where it is really helpful when you can find someone that really specializes in this. And I urge you to get specialized in it, because you'll see a lot more people and help a lot more people.
No, that's really important. And, that's why we're talking to you about it. And on the symptoms, you said midline genital area can you tell us what people describe in terms of symptoms? Because we might have people sitting there who actually have pudendal neuralgia or pudendal nerve entrapment, and they don't know, because like you said, people have this almost cloud over that part of their knowledge.
Yeah. So generally speaking, and I don't have the Nance criteria in front of me, but generally speaking, it's one of the big hallmark features is pain with sitting. So someone will have pain with sitting. And again, if you think about it, there's 2 sides of the pudendal. So when someone says, I just have pain with sitting, I want to ask a lot more questions. Is it one-sided? Do you feel it more on one side? Is it on the other side? It's just all over your genital area? Or where do you have it? Some people actually have high hamstring tendinopathy that they're thinking is pudendal neuralgia. So this is, again, where we want to find out. It's not just enough to say pain with sitting, but that's a start. Okay, so pain with sitting, clitoral pain, perineal, labial, scrotal area, testicular type of pain. And again, there are other nerves going there as well, but in that area. And again, it can be associated with sitting or not. So this is where it gets interesting. Sitting pain was always the hallmark feature. And one of the things they would say is if you sit on a toilet that's open or some form of donut and you don't have the pain, then it's potentially pudendal neuralgia because you're taking pressure off the nerves there. That doesn't always fit. So people get confused. They're like, well, I had pain with sitting, but it doesn't get better when I sit on a toilet. Or, there's all these nuances of what we see. And then rectal pain. So then the question is, you can imagine that if someone has rectal pain and another person has clitoral pain only, is there two symptoms? They get confused. They're like, but is this still pudendal? Because they have rectal pain and I don't have that at all. I have clitoral pain. So there's this lot of it's kind of a catch-all label of saying it's pudendal neuralgia, but now we really got to see, it's just a term saying it's in the distribution, anywhere along the distribution, there's pain. So sitting pain, one of the other hallmark features in the NANS criteria is that, and it's NANTES from France, is if someone is lying down and they go to sleep and they don't have as much pain, that's also a feature of it. It's more with sitting. Also standing isn't necessarily as much typically, but again, you'll see some of our patients say, I just have pain all the time there. And that could be, again, a sign of, do they have an entrapment where there's intractable pain all the time? But yeah, so those are the hallmark features. It's usually some sort of genital type of pain, rectal, perineal area, or clitoral, or sitting pain is a big feature. And especially if it's in that, when you look at the ischial tuberosities, the medial aspect, in there where the Alcock's canal is, when they say that's where they had pain with sitting, that's another hallmark feature.
Would you say that there's typical descriptors, so the words that the patients use to describe this type of pain? And you mentioned the sort of autonomic and motor function. So for those that actually have entrapment and compression of the nerve, what could that present as?
Yeah, it's so interesting because also in the NANS criteria, what they were doing with that is seeing who would be a surgical candidate for decompression surgery. But what's happening, there are a lot of people that meet those criteria that actually should not be getting surgery necessarily because there's so much conservative treatment we can do. But one of the things was if there's a significant sensory change, that's actually not considered part of the criteria, because then they're looking at, is there something else going on that's more neurologic or other things before we just jump to saying it's only entrapment. But there can be sensory changes. There can be changes in the function of the sphincters, for example, motor changes. But again, that's where it gets interesting, because if you're seeing major motor changes, are we looking at cauda equina? Are we looking at, you want to look at all these different types of differentials. And a lot of what I'm doing is basically trying to prove it's not just pudendal. I'm trying to think, is there anything else it could be? And then if we've ruled out everything else, then we go, okay, then we know we have something we can work with in this realm. But I'm constantly trying to figure out, is it something else? So we're looking at those kinds of things, sphincter changes, because the pudendal nerves primarily involved with sphincter control, the ability to contract and relax sphincters, the ability to control bowel, bladder, and sexual function in some way. So if there's changes in those three things, that's what the typical thing we ask about too. Is there pain with bowel or bladder or some sort of change with your sexual feelings there? That sort of thing. We're looking at sensation, motor control, and autonomic is a tricky one because it's more like some people have pain in that area, so they might see changes in blood pressure or other kinds of heart rate types of things, but it's not necessarily one specific thing to say they always have an increase in blood pressure or they always have. It's just how it's going to, how the nervous system will affect them and how what the output looks like for that. And then there's one other thing I was going to mention. We were talking about autonomic, sensory, motor. But the biggest factor to go back to when we're looking at this is pain in the distribution. So remember, that's the number one factor. Though you'll see motor, sensory, and other changes, the number one thing that we usually treat and that we're looking for is, do they have pain? Some of these cases I get are out the opposite, no pain and no sensation. And that's a very different type of treatment or a different look, because now we're really trying to figure out why are they having this much loss of sensation. And I can go into case studies about that, but that's technically not pudendal neuralgia at that point. Because they're not having pain, there's something else potentially going on underlying that.
So just to kind of bring it back to, so a patient walks into the door. That was amazing, by the way, Tracy. This is just my brain going, ooh, this is fantastic. Yeah. So you will often presumably have patients who come in to see you. They've some will have been on this journey for a while and seen everyone under the sun, but you'll have a lot who probably come to you as the first or second, maybe they've seen their general practitioner or something. They come to see you and they've got this pain. So it sounds like, you know, pudendal neuralgia becomes a bit of a diagnosis of exclusion. So you would go through presumably this process of doing a really big subjective examination, finding out whether or not there's any kind of trauma, surgical history, you know, precipitating factors, anything that brought on this pain. You're looking at the quality and the distribution of the pain, what kind of treatments they've had to date, whether they have presumably back issues, any other sort of neurological signs and symptoms. And then when you go to do your physical examination, where do you start? Do you kind of work from the outside in? So do a, you know, start with assessment of the spine and the, you know, other nerves, and then sort of bring yourself in? What does it look like for you? And I know that's a massive question because it's going to depend on your
It does depend on, everyone's a little different. And I will tell you that when I teach the course, I try to give a variety of options so that, you know, everyone has their own way of assessing. What I find, the number one thing, I'll tell you this before I tell you, I'll keep it a secret and surprise and a mystery as to what I do. But what I will say is what a lot of people do that I find is a mistake with Pudendal that drives me crazy, and it drives the patients crazy as well. Super well-meaning professionals. They do a standard screen. So they'll spend the first 30 minutes looking at posture and different, you know, all these different systems. And the person's saying, but I'm having specific sitting pain, and I'm having this one specific pain vaginally. And what happens is they spend so much time doing that, that by the end, they end up doing just a pelvic floor exam quickly. So they go in and do a pelvic floor exam and they're like, okay, well, that's a good start. And the person's like, but I'm trying, you know, I feel like it wasn't addressed what I was actually coming in for. So now juxtaposed to that, what I tend to do, and I was talking to a clinician in my office, we were talking about a little bit differences in what we do. And this is what's beautiful about it, is that we all do it a little bit differently. I'm very much a symptom oriented person. I'm trying to reproduce the symptoms as quickly as I can to try and figure out what's going on. So the way I work, and I know this is very different and opposed to a lot of PTs out there and OTs, is I really want to figure out, can I reproduce the symptoms? So I go to, what are your primary symptoms? Like you said, the history of how did it start? And I want to go to provocation as fast as I can, because if I get closest to the provocation, I've given them a lot of feeling of validation, but I'm also really on the right track of, okay, I can always go back up the systems and look at spine. I can look at other things. But if I can reproduce, I mean, so many times they're like, why has no one ever touched that area? Why has no one ever looked in that area? That's been my pain for 10 years. I mean, I had one patient, she had pain for 20 years. She had multiple surgeries, decompressing surgery. She had anal surgeries done. She had multiple, I mean, I'm talking extensive surgeries. And I touched an area and she's like, that's my pain. Why didn't anyone touch? And so trying to teach palpation, how to find provocation of the symptoms, is really, really important, because the treatment was so easy once we figured that out. So that's really my thing. And so it's different. So for example, if someone has sitting pain, one of the things I do that I find that people are just not doing, I put them in a sitting position and I go underneath, under ischial tuberosities bilaterally. And let's say they have right or left. I'm really trying to feel, and I'm very systematic about it while I'm doing it. I'm going, okay, I'm going hamstrings, anything provocating there. I'll go to hamstring insertion. I go medial lateral of that. I start going on every aspect of all of the tubercles I can in that whole area to figure out, is there something that's just a bony? Is it more bony? Is it more tendinous? I'm trying to figure out. And you'll finally get to the point where you'll be able to locate, that's the area that they have the pain. Now, when you put them in supine, they might not even have that same pain. So they've been seeing people for 10 years that have never really assessed them in a sitting position when they have their pain, just as a simple example. So if they say they have pain with sitting, I like to get them, you know, in that position to try and provocate quickly to see what's going on. Now, if someone's severely limited in sitting and not able to sit at all, I might not be able to do that, because I want to provocate to the point of figuring things out, but not to the point where I'm really irritating them and they're really walking out upset with me. So I have to balance that as well. So yeah, so I hope I answered that question, but I really like to go with, as soon as we can get to the closest to the area, and then I go out from there, as opposed to doing a systems type of approach.
I think, yeah, no, that's fantastic. And I totally agree with the concept. I think with all patients with pain, they want to feel heard, they want to feel validated. If you're faffing around too much elsewhere, especially in that first session, they probably won't come back. you know, if they feel like you've not even got near to where their pain is. So no, that was
I do think some of that comes down to a confidence and being educated. So for example, after I'll teach the course, people say, I didn't even think to check these 5 places, and now I feel super confident to do it. So what happens is they go to their natural, which is I do my posture and then I do some pelvic floor. So they tend to do what they know. But once you give them more tools and more places to palpate and confidence, like this position's really good to test for this, it gives them a lot of empowerment to then try those things. So that's really where my mission has been, is to give you empowerment to say, it's okay. I know no one's taught you how to do a child's pose rectal evaluation, but this will help so many assessments and for patients and really figure out what's going on. So they're like, oh, you know, wow, this is amazing to have that knowledge, to know that I can do that, and that will help so many more people.
Yeah, it's interesting, right? That being able to listen to the person, this is what I heard you say, being able to listen to the person. And even though it sounds like it might be altered sensation, altered motor, altered bowel, bladder, sexual function, you know, the pain is a big one for you. Like, I mean, it sounds like that might be the distinguishing feature between that and a quarter equina presentation, for example. And then listening to them and saying, okay, you get the problem when you sit. Let's have a look and examine in sitting so that we can see what it's like. Yeah, it's nice that it happens. It's a shame that we still have to keep educating like this, but that functional assessment, but I think even more importantly, like you said, being able to put your finger on their pain so that they feel like that they're not just giving me the run of the mill. They're not just giving me pelvic floor exercises. They're not just telling me to change my posture, but it's like, you see me and you can put your finger on where I have the pain. So
Yes.
important to get that initial buy-in, right?
And so, for example, there's for men that, for those that are dealing with, they have penile type of pain, or they have some sort of testicular in that area. Okay. When they have pain like that, you'll see a lot of people that just were trained in that area to go and do a pelvic floor exam. So they'll go and do a rectal exam, and they'll go and do, you know, maybe touch around testicular a little bit. But in some cases, you have to be so specific to go along the spermatocord up towards the bulbospongiosis, and then even lift up. So you can see my hands, I'm doing the whole procedure here. But you want to lift up and go underneath and go sometimes even to the shaft of the penis. You're trying to get to the area to figure out, does any of this reproduce it? And if not, you've at least covered that area. Whereas I feel like people, they feel again like they've been heard, like, wow, you're really trying to find it, as opposed to just doing a standardized care where it's really not going to get to the area. Then secondly, if you're doing a rectal exam, again, we've been taught to do a lot of like side lying and doing pelvic floor, where in the course, what I teach is that actually the dorsal aspect of the nerve, a lot of times things are missed at the deep transverse perineum. So in that area, because it's actually, it gets so tight through there, and or around the prostate itself, and where there's a junction, if you have someone at the junction of where the deep transverse perineum is, the prostate, and then that area there is where the dorsal aspect of the pudendal nerve might be sitting in that area. It's really anterior there. And so there are people, like, if you can just get prostate mobility and or that whole area, just palpating in that area, it's amazing how many symptoms will say, that's my penile pain. But if you're only doing pelvic floor, puborectalis, you're going to miss that every time. So it's knowing where to palpate and how to have that confidence to know that you're in that area. So you're like you said, you're also saying, aha, I'm listening to you, and I'm also able to touch that area where you're having that discomfort.
Can you come to Australia and teach me?
I'm absolutely able and willing to come to Australia. Absolutely. I actually started my Pudendal Tour again, where I'm starting to go live again with some courses. So yeah.
Okay. Can everyone who's listening to this, like, shoot us an email or comment on the post and let us know who wants Tracy to come to Australia. And I think we should rally the troops and make it happen. Maybe like go over to Sydney and see Anthony and Melbourne, and then come over to Perth. Or I can come over to Sydney and Melbourne. That's fine. When
are we doing this? Let's do it. And obviously I'm super passionate about it, simply because I see things missed for so long. And the patients continue to say, I just wish someone had caught this earlier and knew to look there. It's not that I would say it's not that I'm doing something magical. It's just, identifying it and then being able to, and even sometimes, again, we know from pain science that even just identifying it and starting to touch in that area and having some sort of connection with the nervous system has a major effect as well. So there's a lot of that too, just knowing that you're in the area and you're now working together, you know, in conjunction with the patient makes a huge difference for the nervous system. So
that's awesome, Tracy. For those who are listening, you know, you did a great job outlining that functional and specific testing based on your anatomy, listening to the person. What about the whole journey? Can you mentioned case studies? What sort of case studies, so that we can understand the whole journey of what initial presentation through to conclusion might look like?
Yeah, so I will tell you this, there's something, before we get into any specific case studies, there's something, the reason why I'm also super passionate about this, and why someone says, well, why are you focusing on Pudendal? I mean, I treat all complex pelvic pain. So cases that have been missed for many years, I really like pelvic pain, whether it's dealing with vulvodynia, endometriosis, any of these umbrellas of under pelvic pain, I'm really passionate about it. But I feel like Pudendal, what happens is if you go online right now and you look up, you think, oh my gosh, I finally feel like I know what I have. I have Pudendal neuralgia. And you go down into you start reading about it. People come out feeling significantly depressed and hopeless because it'll get conflated, like I said, with saying that they have pudendal nerve entrapment and that the only cure is going to be some sort of major surgery, or you're just going to have a lifelong feeling that you're going to be sitting and you're going to have pain for the rest of your life. And I've just seen enough cases to know that this is not true. And there's so much more hope. And so, you know, I think that Pudendal has a distinct kind of demise type of thing when people start looking for help. And I've been trying to get more information out there. And this is why I love to do these kinds of talks, because it's an opportunity to say to anyone out there that's listening, there is so much hope. It's just a matter of figuring out what's going on. And so we just have to keep figuring out what that is. There is a Pudendal Tour, is what I call it. And it's an actual tour where patients will see, because it's so compartmentalized in care, where you have someone that's an expert in cryoablation. You have someone that's an expert in pudendal nerve MRNs or MRIs, so what people start to do is they hop from place to place. And these are people that might not even have the means to do it, but they spend their entire savings to do this. And it breaks my heart. And I just want to grab them as soon as I can and see what we can do before they go down the full tour. So the tour could look like going to Hollis Potter in New York for some sort of MRI test, because she specializes in looking at the pelvis and pudendal nerve. You might then find yourself going to Michael Hibner in Arizona, because he does a lot with Botox for pelvic floor. And he's amazing at pudendal nerve decompression surgery. You might find yourself in California with someone else that does MRNs, specifically looking at the nerves there. You might go to Atlanta, where there's Dr. Prologo is doing cryoablation of the pudendal nerve. So you can imagine a lot of these patients we've seen have gone to multiple places. Then they start to go to Dr. Osman in Europe and all over, looking for this magic thing to help. And it's because they're going online, trying their best to get the best care. They really are trying. And so my goal is to get enough of us trained where we can do the palpations and figure out, can this really help with conservative care, as opposed to people thinking they have to get a pudendal block or they have to get some form of MRN or they'll never get better. Because sometimes it's good to have that information, but a lot of times I tell patients it's just more information. It's not necessarily giving us the path yet to what's going on. And if anything, that stuff is ruling things out. So now to segue into, for example, some of the case studies, I'll tell you an example of someone that was not pudendal, but came in thinking they had pudendal. It was a guy in his 20s who came in from another state, and he said he didn't know what was happening. He wasn't no longer having erectile function, which can happen with pudendal sometimes because of motor function. He was not having erections, and he said he was always cold down there, felt super cold. And I'm thinking, yeah, this is not the typical, he didn't have pain with sitting, he didn't have any kind of pain, it didn't seem like the typical thing. So when I was doing my exam, I was trying to figure out, did he have a hernia or some sort of thing that was basically pushing into the nerves, creating a compression? Did he have some other kind of spinal cord? We were trying to figure out what's going on in that regard. And I sent him to a hernia surgeon to have him get some imaging, because and this is another thing, the more you know, the more you can know who to refer to. It becomes super clear where you need to refer. So I sent him over and I said, it seems like there's some compression somewhere. This is a form of entrapment, but I can't place what it is. Nothing was showing up in my musculoskeletal type of exam. And even my neuro type of exam, nothing was showing up. other than it was cold and there were no reflexes. So it's like, cremasteric, that type of thing. There was not that kind of reflex. So in his case, he had a tumor, a femoral tumor pressing up in that area. And so they caught the tumor and they were able to start treating immediately. But so, it's sometimes, again, ruling out what's not pudendal. That's just one example of many that I found that actually were not pudendal. And he even made a comment, which broke my heart too. He said, well, I guess I'm in my 20s now. Maybe I just won't have as much erectile function. Maybe that's normal. And I was like, oh man, no, it's like, I'm so glad you made it here, because now we can figure this out for you. You could have wasted years trying to figure this out. So that was good. Another case of where it was really conservative care was a patient who I talk about the story a lot because it still is fascinating to me. She came down on a mattress in the back of a van, and she was having severe pain, could not sit at all. Anytime she tried to sit, she immediately had the worst jolting vaginal pain ever. severe and deep, and genital pain, and was miserable. She couldn't work anymore. She couldn't do anything. And she was scheduled to have a bilateral pudendal nerve decompression via piriformis transections, basically, some form of piriformis cutting bilaterally to release there, to therefore reduce her pudendal symptoms from sitting. And I'm thinking that just doesn't make sense. Why bilaterally? And why would she need to do this decompression surgery with piriformis? I palpated her piriformis, not a symptom provocation at all. Sitting stuff, it was not coming from there at all. So I said, can you do me a favor and not jump to that surgery? Let's continue, wait. And so did a thorough exam, a vaginal exam, and she had some symptoms and couldn't figure it out. And finally asked her, I said, do you, tell me all of your history some more? And we went into more of her history. And in her case, she had a abdominoplasty 2 years prior. And for some reason she was fine, but then, maybe it was even 3 years prior, but her symptoms started maybe 8 months before I saw her. So something happened. And so when I went along the abdominoplasty area, and especially when I did bimanual, so on the abdominoplasty and then internally, vaginally, that lit up everything, the anterior vaginal wall, and where I could go where that incision, where the scar tissue was, that lit up all of her symptoms. So she would have had the totally wrong pudendal surgery when she did have pudendal symptoms, but it was coming, technically it was actually a totally different presentation, where it was pelvic nerves and it was actually deep vaginal, anterior vaginal wall, as well as her scar tissue. This is, again, another example of many. So we're constantly looking at what, and she said no one in all the whole time of that 8 months when she was in her own state, no one even looked at her abdominal wall or asked her about it. So she was going down this whole other track again of people thinking, oh, it's just labeled as pudendal, so it's going to be pudendal. So, and again, there are cases. can I highlight one more big thing? There's so many things I want to say. But the other big thing that is pudendal nerve entrapment that gets missed as well, so I shouldn't say as well, but that gets missed, that I think is super important. Whenever someone says, I had a hysterectomy and they had no pain before, they had a hysterectomy, they wake up, and within a day or two, or that moment when they wake up from surgery, they immediately have the worst, most excruciating pain, pudendal distribution pain. That is an entrapment. That's a surgical entrapment. So what a lot of times the surgeons will say is, why don't you just, wait, let's wait 8 months, let's wait a year, let's see how it goes. Those are the cases that need either to be taken right back into the OR to get that surgical material, whatever it is, whether it was suture or something happened that was left there, it needs to be taken out, or they need to see someone that specializes in these surgeries at some point after that fact, that really, like a Dr. Hibner who understands how to do that, to get to before it becomes severe or they have more problems there. But that's the big red flag of that is pudendal nerve entrapment. Not obviously, usually it is pudendal nerve entrapment. And so this is where someone says, you'll see someone in the forums, this happens a lot. They'll be in a pudendal forum, they're like, hey guys, I've been having pain since my hysterectomy, and I'm basically it's intractable pain, I don't know what to do. And someone will say, oh, I also had pain, vaginal pain. I'm like, these are what they're talking about are two totally different things. And I want people to know that that's the red flag. That's not something that therapy will typically help with, that you can just do, 2 months of pelvic therapy and everything will be well. It's something they really should get a surgical opinion again. Just as
that's awesome. That's really helpful, actually, because I work in a large women's hospital, so I'm gonna definitely keep a close eye on that, and also let all the physios who work up on the wards know to keep an eye out for that as well. Because if you say that it's presenting really early, they might even notice that in those first couple of days. Which would
And
be
there is nuanced things. So for example, there are cases where post hysterectomy, the vaginal cuff, so where they were supposed to take all the nerves up and put them into a nice little, pull them up and then suture. Sometimes what we find is that they actually left a little bit of the nerve endings there and closed it. So there's actually can be problems directly at the cuff. So when I'm doing my assessments, I'm actually going to the cuff to see, does that actually reproduce a lot of their symptoms, or is it some other kind of provocation? So that's important to do that. Then in that case, it is potentially a redo of surgery or some other kind of treatment, but it's not necessarily a true pudendal nerve entrapment in the way that we talk about in other ways.
Yeah. Before we get on to what physio management might look like, because I imagine we're going to head into a nice biopsychosocial approach to helping people with pain. I just wanted to ask a little bit about postnatal or post-birth pain. So some of the precipitating factors that might lead people to struggle with pudendal neuralgia post vaginal birth, and what that might present like, because I think that's
that's a tricky one too. I've talked to some of the surgeons who work with people who've had long-term standing effects from postpartum type of, during delivery and then started having pain. There's different cases of it sometimes, and this is where it's really fascinating when you really do the differentials and you're doing assessments. Sometimes the pudendal-like symptoms are truly pelvic floor tightness. It's more truly under the pelvic floor umbrella. So then we know that treatment would be quite easy, relatively speaking. Sometimes we see where there were forceps or vacuum types of assisted deliveries, where there was some injury there and may even have an avulsion as well, some sort of levator ani avulsion. And then you're dealing with, this is where it gets tricky. Sometimes you can do enough kind of like we're talking about biopsychosocial touch and do some things in terms of neuromodulation that just calm down the symptoms and get some nerve function back and everything's relatively okay. There's another class of people that I feel like have almost like, I don't know if I want to use the word demyelinization, or demyelination, but they do have a true nerve injury that can happen in those cases. And I think those are trickier because they're having a lot of pain and dysfunction as well there. The sphincter dysfunction, they're having a lot more. It's a lot of dysfunction there. And I always am someone that will try everything I can because I'm so hopeful that we can help these patients. But I feel like there are a certain amount of percentage, probably a low percentage of the whole birthing, but there are people that probably do have some actual nerve types of damage. And the question is how bad, where on the spectrum is it? So I hope that helps to know that it could be anything from pelvic floor to nerve injury.
No, that's really helpful, Tracy. And it sounds like there's lots of differential diagnoses. There's lots of things to exclude. There's lots of things to include. There's, you're referring to different people for different types of presentations. Can you explain what our role, because all three of us happen to be physiotherapists, but whether you're a pelvic health professional of some sort, a fitness professional, or just a member of the public who might have these symptoms, how does working in a team, a multidisciplinary team, how does that look like for assessment and management?
So this is a question I get quite a lot in the courses is, okay, I'm hearing you talk about all these different tests and blocks and things you can do. What do I do now? How do I create this team? And this is tricky. In my area, what I look for, I need to find a hernia specialist that I really believe can do well with looking at imaging and knowing what's going on with hernias. I need to find someone that's an interventional pain radiologist that can deal with doing blocks if we need some blocks and things like that. You need a GYN specialist, someone that really understands pelvic pain and pudendal. And by the way, I'm understanding that not every city has this, but I'm telling you, in an ideal world, you'd be finding a urologist who can handle those kinds of things as well. So I'm constantly trying to find, and then I'm trying to find a gynecologist who understands menopausal changes and too, because that a lot of times it's estrogenic issues that are being masked and everyone thinks they have pudendal neuralgia. I can't tell you how many patients for 10 years, they thought they had pudendal neuralgia. We got some vaginal estrogen on them. And within 3 months, they had no more symptoms, but they were told that they had genital pain. So they thought it was pudendal neuralgia. So you really want to find, this is where it's kind of finding all these different people and you're like collecting them. And then sadly, a hernia specialist leaves. And I'm like, no, don't go. So, because then you got to find the people again. Sometimes, unfortunately, I find that I have to get people even out of state So because it's so specialized, if I really think someone needs specialized Botox or something for pelvic floor because they're dealing with this one issue, I might have to say the options are really not that great. But if you're looking for something, this might be an option. I want to at least give them their options to try this. So it's basically like handpicking and trying to really develop relationships like everything else. It's clear. And, we're all good at different things. And so I think sometimes the other thing that I do that I think has been super helpful is in my note or when I contact someone, if I really think I already know what's going on, I'll prompt it, because that could also help to say, hey, I noticed that when I touch the cervix, there's extensive, that's where the pain seems to be reproduced. Would it be possible for us to explore that more? Instead of just sending them to that person to say, hey, they have pudendal-like pain or they have vaginal pain. I really try to give a little bit of like this. On my assessment, I found that directly at the anterior surface of the cervix at 1 o'clock, that this is exactly where they have their discomfort. Would it be possible for us to explore that more? So sometimes I do a lot of prompting to then help with that team along the way too. So
for those, Tracy, that you think will do well with conservative management and are not probably going to need to go down that route of surgical intervention, nerve blocks and things like that, what might physio management look like? Because I feel like perhaps people think that it's all about pushing on, tender spots or trigger points or whatever you want to call them, and wands and really sort of always manual therapy type things. But I'd like you just to give us an idea of what that sort of nerve, what's the word I'm looking for? Yeah, looking after the nerve health, that kind of
health, yes. So when I teach the course, from a manual perspective, the way I teach, again, is super biopsychosocial. I do a lot of explanation of really there's direct and indirect techniques. So I even just want to see, just by touching someone, again, I know, and we've talked about this at length. I know you do in your podcast. I know for years we talked about this. Are we doing what we even think we're doing? No, I don't know that I'm doing the effect that I think I'm doing. I'm merely just trying to get input into the nervous system. So I'm just trying to even see with touching in that area, now that I know where the area is, can I basically approximate tissue? And they say, oh, that feels so good. If they tell me when I'm approximating tissue and gathering it instead of being really heavy with direct manual techniques, if I'm just even approximating tissue and they say, whatever you're doing, please, that helps me so much. I tell them, even the fact that even for those 2 seconds that you feel that relief, that's still a good sign that your nervous system is responding. And again, I don't say anything fluff just to be like, oh, this is going to, it's a miracle. It's more like I just try to say, like, this is a good thing that we're getting some input to the nervous system. And they'll say, yeah, but then when you take your hand away, I feel it again. That's okay. We know that we've actually done something that can modulate there. So we're going to continue to figure out what you can do at home to support that. We're going to figure out what we can do in the clinic to continue to support that type of thing. And over time, over time will get better with, you'll notice over time that it is improving, potentially that it will improve. So I'm going to help, it's this whole idea. I talk a lot in my class about, I'm facilitating. We're working together and I'm facilitating. I never say like, this is what I'm going to do to you each time. And each time you're going to get better. I use a lot of that language of I'm facilitating. We're working together to figure this out. So I do direct and indirect manual techniques just to even see if there's a change. I'm always looking to test and retest. What can I do to that the symptoms provocate? Can I do something to make it better? And I know you two are very much a fan of that as well. Then when it comes to looking at overall, I think the other thing that I do quite well, and I don't say this lightly, is that I think it's really case management. And that's the thing, the more that you can become more comfortable with these kinds of patients, the better it'll be. For example, if someone presents with really tight pelvic floor as the presentation, and really you can find spots that are tender, I don't do any trigger points, or I'm not trying to mash on the muscles. I'm trying to figure out what makes sense. What can they do at home to down train pelvic floor? What can I do in the clinic that I was saying to do something to interact the nervous system that can down train everything? And then I'm also looking at it, like if they're not responding, within 3 to 6 visits, I feel like we should start to see some change. If we're kind of going along the path, even if it's 1 point drop, I'm trying to see is something changing. So then I start to see, do they need other intervention? Would this person benefit from going to someone who also prescribes some form of muscle relaxer or vaginal or rectal suppository? Do they also need some other kind of support? If they say, hey, I've tried acupuncture and it seems to help, the research doesn't necessarily always support that, but if they say that helps their nervous system, say, we're going to try to put everything we can together to support you. So if you feel like that was also helping your symptoms, that might not be a bad idea to put that on the recipe as well. So I feel like I'm collecting things for a recipe for them, and they really feel supported that way. When you put it that way, like we're collecting things that seem to help you to ultimately get you to the point where you're moving better, you're feeling better, you're sitting better. So it's kind of a process of collecting the good things, is how I do consider.
Oh, that sounds amazing. And obviously sits to our bias, doesn't it, Anthony? But I love this concept of, you do something and it creates a bit of a change. And that is so good for the patient, because they're like, oh, something's different. Like, even if it's just for that little moment in time, something is different. And if you've had chronic pain for 10, 20 years and nothing changes, I can imagine how powerful that is for the patients. I have a little bit of a question, and it's funny because this actually came from a conversation with my husband this morning, and I don't even know how it came up, but he mentioned, oh, someone at my work had back pain and he went and had all these injections and stuff and nothing helped. And then his physio gave him these flossing exercises and all his leg pain has gone away and rah, rah, rah. And I said to him, oh, it's funny you mentioned that, because we're going to be talking a bit about nerve pain, and flossing for the pudendal nerve might be quite tricky, I imagine. Or is all like, I mean, we know that the nervous system is all connected. So movement generally, if it's multi-directional, multi-limbed, is probably going to do something along that nerve. But do you have any particular exercises that you think are probably better in this population?
Yeah, so this is also where it's interesting with movement. So when you go on the forums, you'll see that people will say, I was told to never sit or never squat or don't ever do these movements because it'll basically damage my pudendal nerve. And by the way, for anyone out there listening, there's not really many movements or things you can do that will damage your pudendal nerve. We're super resilient, and this whole idea that even if you have pain when you do it, you damage the nerve is just simply not true. Okay. But what I will say is that it's so person dependent. One thing is that you can't really mobilize or floss the pudendal nerve because it doesn't cross a joint. Okay. So when you see people teaching, okay, this is how we floss the pudendal nerve, and you understand the anatomy where it's going deep inside the pelvis. What I tell people, if you're on the tissue around, let's say sometimes people will do what they think is a mobilization or a flossing or a nerve glide. They're pushing down on the ischial tissue and then having the person lift up their bottom, and they're calling it a nerve glide. I'm like, great, you're doing some tissue mobilization. If that feels good for the patient, awesome. But you're not technically, you're doing maybe a form of glide in the sense that it's moving in that small area, but it's not a true nerve glide we think about when it crosses joints. But sometimes I do, in fact, I'll do sciatic type of flossing and things because there's the nerves in that area, and by the way, a lot of people have sciatic-like symptoms, but they think it's pudendal. But when they say, oh, but it's also going down my leg, I'm like, aha, it could be, because S234, it could be there, but also could it be that you have something else going on spine or something else going on? Let's do the nerve. Then it makes sense to do some more nerve glides. And some people will try to do a little bit more obturator types of glides, but true pudendal gliding you can't really do and call it an official glide. But can you do tissue mobility in that area? And if it helps them, awesome. So again, it goes to my whole idea of just being able to just tissue move in where it feels good for them. So in terms of my prescribing of any sort of exercises and things, I tell them it's always like, go do anything that you want to do as long as you're not having major discomfort or flare. Even if it's a little bit of discomfort and then you can bring it back, awesome. Keep doing things that you do. Like someone say, well, I was told to never sit. And I was like, but you can sit now for 10 minutes. Yeah, okay, then do it for 10 minutes, try it for 11 minutes sometimes. This whole idea of just empowering them to tell them that they can do things and get moving. So I do a lot of movements where we're ultimately trying to get them to squat more, trying to get them to sit more. We're doing a lot of progressive overload in a way, getting them to the point where they can do it instead of backing fully away. But it's any movement that they're having trouble with that they say they can't do. Okay, we'll back away. And then just like we do in strength training, it's like, now let's scale you wherever you are. It's a lot of scaling to get them to where they can move and do what they want. And so many patients are like, I was told to never do this for 5 years. I'm like, well, you're doing it right now and you have no symptoms. You told me you didn't have any the next day. Nope, not at all. Great. So it's a lot of just figuring out what works for them.
That's fantastic, Tracy. It's always good to hear such an empowering message. The ability to show people that, hey, you can do this, and to be able to work with them, you can change their symptoms, and the tissue mobility thing, you know, for the health professionals, we get really pedantic on things. At the end of the day, what we're trying to do is change the symptoms in some way that seems beneficial, right? And I was thinking back to what might have been my first experience with pudendal neuralgia-ish, maybe, is, you know, it was 23 years ago. I'd started, there was a cheerleader, and she had what seemed like high hamstring pain, but it was too medial and too high to be high hamstring pain, you know. And in the end, I landed on obturator internus, and I'm, you know, I often actually think back to this lady and think, well, maybe it was something else like pudendal neuralgia, because sometimes, you know, things like pressure and sometimes they like movement and decompression, and I really loved hearing that come through what you've been describing for us. And what's really interesting is that there's so many different modalities that can also be done. Did you have any other things that you wanted to share to do with some of those things, like when should somebody go get a block or an MRI or a Botox even, or some of these other things that are available to them?
Yeah. And by the way, to back up what you were saying, that, so remember, the obturator internus, the fascia is where the pudendal nerve comes through. So this is where, again, it gets into the nuances and gets into semantics sometimes of, is it an obturator internus issue, or is it the pudendal nerve going through the obturator fascia? And sometimes it's both. It's like you have some tightness of the obturator internus muscle, so therefore you have an irritation of the nerve. And by the way, I say that a lot. Patients say, oh no, I must have pudendal nerve entrapment, or I have the worst pudendal neuralgia ever. I'm like, well, your nerve is possibly irritated. That's what seems like it's going on. When I touch there, it seems like you're getting irritated in that area or having some discomfort. So therefore, it's the best way I can say it. When I say irritated, they're like, oh, okay, that doesn't sound as bad. And I'm not also trying to be, you know, I don't just want to say things just to make things better, but sometimes it really is just that, it's an irritation. And whether, again, semantically, it matters whether it's the muscle or it's the nerve. You know, in that area, it's probably both. Like we talk about, you know, you can't just isolate in that area. You have the muscle that's being innervated there. So it's, you know, it's a tricky
and that's such a good point about the language, Tracy. We're trying not to scare the crap out of our patients and send them down these rabbit holes of despair and depression and anxiety and everything around that. And the choice of words of, oh yeah, this area is a bit sensitive, or this nerve seems a little bit irritated, feels quite different to, you have this scary diagnosis.
Yeah, I spend a whole section in the course going over how to be non-nocivic with your language. And I give examples of how to do that. And it starts even from when, you know, the person calls our clinic. The whole idea is to, you know, bring them into a place where there's hope. And again, not false hope. I don't like that. And I don't like the whole toxic positivity, like everything's awesome. Oh, you have pain with sitting, you can't sit at all, but fantastic. You know, I'm not trying to be a cheerleader in that way. It's more like, okay, now we have a good baseline and we're going to work together to really figure out what makes the most sense and give them, like you said, a lot of empowerment and hope, but with actually doing it, with figuring out the steps to do that and letting them see that. And it's not always easy. I mean, to say that I've helped every single patient I've ever seen would not be correct. But I can tell you that I've seen a lot of cases where they were missed for years, where it was something we could just do conservatively and sometimes add a few things that really did make a difference. So to answer your question in terms of MRNs or MRIs or any of these things, I tend to work on trying to do none of that first, if possible, because it really might just respond to local types of therapy that we can do, home exercise first. Okay, we do a lot of that. And again, and this is the other thing, I don't have them try for a year or two before we, you know, I know within a few visits, are we on the right track? What do we need to do? And again, that comes with confidence and seeing more of that. But there are people that just say definitively, I just want to know. I want to know, you know, is it my spine? Is it the pelvis? So in those cases, when they really just want to rule things out, make sure they don't have a tumor, make sure they don't have any other kind of problem, I try to explain to them, you still might not know about your pudendal nerve. So go into it knowing that even with the best imaging, MR neurography is what it is. If you do that, it's supposed to be really even highly better skilled at seeing You can view the nerves better, but the pudendal nerve is really hard to view. So people, and then by the way, there's a bias too with this. There are some radiologists, you can have the same person go to two different people. We've done this before. Two of the top experts in the world in MRIs or MRNs of the pudendal. One will say scar tissue on the right. The other one will say no scar tissue. And then by the way, they get a surgery done and it turns out they had scar tissue on the left. So it's fascinating that even with the best imaging, so I tell patients that this is just a guide really more to figure out differentials or we're missing something, but I don't tell them like, we're going to put all your eggs in this basket of you're going to get this, you're going to know what's going on with your pudendal nerve, because that's where I can help educate. Do you still want to do that? I give them the idea of what to expect and what not to expect. And that helps them decide, yeah, I still want to get this done, or no, I don't. Or I can say, it seems like your symptoms may be coming from your spine. There's certainly some things we can do to help you. But if you had to pick, if you're deciding pelvis or spine, in this case, it may make sense to first go to a spine specialist and have, I kind of guide in that direction. That makes sense if you wanted to get imaging, to consider talking to them first. So I do a lot of guiding based on what I'm finding in the clinic. Blocks is a really interesting one. I had a question the other day come up about it. And this is where, again, knowing the nuances of the treatments really helps, or the tests. So for example, there's two kinds of blocks. There's one where they do it CT guided, fluoroscopy guided, US guided, and they do it interventional radiology. They have you on your stomach. They do it near that claw area. They go in and do the block. And what's happening is it's going to be super technically, I guess you could say, into that gluteal area. So is it really going to be able to get an effect at the clitoral branch? I would say no. And many people that are seeing this clinically, we see that if they have clitoral symptoms, doing that block may not be a true, positive test, or a true negative, because it just might not be getting deeper to the area. Then you have those that do vaginal at the Alcock's Canal. And people are like, well, what's better? Because they're not guided. So people who do a lot of those, who are gynecologists trained to do that, they were doing this for obstetrics a while back. They're really good at doing that, but they're going to have some false negatives as well, because they're not necessarily going to hit the anatomy every time. But you don't want someone that's never done that transvaginal to do it that way, because if that's not what they typically do. So really, you have two ways you can do it. You either have to go to interventional radiology to do it, and that's what they do, guided, or you go to someone that's a pelvic pain specialist that does those blocks regularly, but they also might miss sometimes. And you just have, that's what you'll just have to decide if you're deciding on blocks. But again, even if you have a block and you have 24 hours of relief, okay, cool. It's probably your pudendal nerve. Now we got to do the treatment for it. So it doesn't really necessarily change what we're treating, but it may give them some idea of, okay, we're in the right area. As opposed to, that didn't help me at all. Now what? But again, it might not change my treatment at all, because I'm still looking for how I can help their overall symptoms.
That's awesome, Tracy.
So much to say. It's like, there's so many things that, this is why I'm so glad to have this opportunity. And I thank you for it, because there's so many things that just, that it's not just treating pelvic pain, it's understanding the journey of the patient and the information they're receiving, and trying to help them guide through all of that as well.
Yeah, no, I think it's so important, because if more people know about it, more people can look out for it, even if it is just to say, hey, message this woman that I heard on this podcast. She seems to know a lot about pudendal neuralgia, pudendal nerve entrapment. Like, I was sitting here thinking, because I've got people that I see a lot of low back pain. People have sciatica and bend over and touch their toes. To me, that would be pain in the sciatic region, right? In the sciatic referral pattern. And then I've got people that have a straight leg raise of 20 degrees on one side and 90 degrees or 80 degrees on the other side. It's like, yeah, that's probably going to be closer to radiculopathy and, something physically trapping the nerve. And, it sounds like there's all that nuance that goes into, okay, where is this happening? Are there any other simple examples that you can help people just understand just a little bit more about those two? What would you say the 2 points between pudendal neuralgia and pudendal nerve entrapment would be?
Yeah, the biggest thing is, think that first, like I said, just to reiterate, pudendal neuralgia is likely the majority of people that have pudendal-like symptoms. So that's already like point number one. Just chances are it's probably pudendal neuralgia and not entrapment. Entrapment, when we think about it, it's more intractable. The pain is just the worst pain of their lives. They just really are miserable. There's a feeling that it's not going away, and it's a lot of times deep. So that's where I can get in that claw area, for example, where it's deep, gluteal. They just can't sit. They're not comfortable all the time. They have a different presentation than someone that comes in and says, yeah, I just have some pain when I sit and it's bothering me. This is like an intractable deep pain. And then also, when you look at their history, they've had some form of traumatic fall. One case was really interesting, a skier that had a significant traumatic fall and had major scar tissue along the whole pudendal area, claw area. There's another one that actually was sitting on like a seat, like a bus seat, you know, the side of the seat for a long time. And I guess it was bumping, we're talking hours, and ended up developing such bad pain that they found that also ended up being intractable over time, and probably had some sort of jarring traumatic injury in that area. So there's usually some sort of injury that happens. There's three things, and it could be the hysterectomy, major injury, or the thing that's really the hardest is there are congenital cases where someone's noticed over the years they've been doing a lot of squats. A lot of times we see this in bodybuilders or people that are doing heavy lifting. And they're like, over time, I'm noticing that I'm just getting more and more symptoms and nothing's making it better. The more that they exercise, it's getting worse. And then when they go in and do the surgery, they do in fact find that it was like, I mean, the two sacrotuberous and sacrospinous ligaments were so taut on that nerve. I mean, there was no way. It was just completely congenitally that way. And actually, on that note, we did a cadaveric dissection with Dr. Mark Conway at one point. We had a really cool lab at IPPS, and I was standing next to him, and he's one of the other pudendal decompression surgeons. And he said, look at that. That is major pudendal nerve entrapment. And he's like, I really wonder if that person had symptoms their life or not. Because like that, anatomically, this person had significant entrapment. You could just see where the ligaments were. So it's kind of like some people probably do just have it anatomically. So those are the three main factors or main things to consider. Of course, the congenital one is the hardest one. Sometimes it will show up on imaging. You'll see hypertrophy around that area or some changes anatomically, but that's a trickier one. But again, you've ruled out everything. You've already tried all the conservative treatments. You've already looked at everything. You want to do everything you can to prove first, and then we move into that section. Yeah.
That was a great summary. Thank you. Thank you very much, Tracy. I think if you're happy for me to just to summarize what we've done, what we've talked about today, and then if there's anything you want to add on top of that, I think this has been a brilliant introduction for a lot of people as to, you know, pudendal neuralgia versus nerve entrapment. So you've really helped sort of elucidate that people can present in different ways, that the vast majority are going to be the neuralgia, but we need to be aware of the entrapment, and they can be popping up. You've talked a lot about the anatomy and this complicated path that this nerve actually goes through. You've summarized some of the symptoms that the patients might present with, the types of pain, some of the potential causes of this pain. You covered how the nerve has those different, that has the autonomic and the sensory and the motor elements, and again, how that might present. You summarize the NANT criteria and some of those things that we should be looking out for. The importance of reproducing symptoms, and I found that really interesting because I have to admit, I don't know how to assess in sitting. I've not done that before, and I'd be really, this would be great to get you over. And and I think I really need to, in my head, understand the anatomy better and feel more confident with assessing in different positions. I absolutely would love to learn more about that. You talked a lot about this Pudendal Tour that some of the patients might go on in America, where they might be going over here to have nerve blocks, going over here to have this, you know, assessment scan, etc. So they really might be spending huge amounts of money to get some answers, and it's not always helpful, unfortunately, for a lot of patients. You also mentioned that it's really important, if you're working with this with these patients, that you get a really good team around you, because you're going to need like a hernia specialist, you're going to need a radiologist who's good with working with pain, a good gynecologist, a urologist. So that's going to take, I imagine, a bit of time and experimenting with, you know, different patients and stuff to really work on finding that team. And then you talked about what types of assessments might be helpful, and then what that physiotherapy management and multidisciplinary management might look like. So I feel like you've covered a huge amount, and I know that within your courses and things, you'd obviously have more time to go into that in a lot more detail. If there's anything you want to add to that, please do, Tracy, but I'd love you now just to talk about what the training that you do for health professionals, so that people, if they want to learn more, can learn more.
Yeah, so it's interesting because I would do these 2-day lab courses where we would go over as much of this as possible. I would go into physician or medical treatments. I'd go into the testing. I'd go in, I'd have lots of different blocks, and then we do the labs, right? And when the pandemic happened, I had to move everything online. Okay. And I was like, oh no, I hope it still translates. And it turns out that it's actually freed up time. So this online portion, you can get a lot of this didactic, go over anatomy, go over more of the general basics. And then now what I'm going to do, I'm going to Dubai and I'm going to Canada and a few, possibly 1 or 2 places in the US, and I can absolutely start traveling other places. The idea is to then have 2 days of true lab where we're going over case studies. We're going over actually hands-on palpation and teaching, like I was saying, all the positions and things to consider, differentials. So for example, vulvar pain, it's like, people say, is it pudendal neuralgia or is it vulvodynia? Is it, even if it is vulvodynia, then is it neuroproliferative vulvodynia? There's so many things to look at and consider, and it's hard to remember it all. I don't know why, just over the years, it's just like my brain is constantly like going through the differentials. That's how you just start to get that. And I'm sure I miss things too, but it's this whole idea of now making it more hands-on for the 2 days. So that's what I try to do and impart for health professionals, is just improving your understanding of the variety of things it could be. And so that's some of the feedback I get from the course, is it just opened up my mind to understand that I've been missing things, or different positions, or ways to consider working with a team better, and how to reach out to people. And I even talk about, again, from documentation, how to write that or how to express that, to how to communicate with other people as well. And again, I use a lot of open-ended questions. This is what I'm thinking. Would this be possible? Those kinds of things. So yeah, that's what I do. And again, I'm just starting to roll that out. I'm sorry.
Oh, I'm sorry.
What were you saying?
Within your Pelvic Guru business, so
Yes.
do you have some online teaching? So is the online teaching always a preemptive to the hands-on, or do you also have some that are standalone courses that are online?
That's actually what I've decided to do for this round this year, is that, going to 2024, is we're going to do, where you really should take the online course that I have as kind of a hybrid, and then we'll go into it more in depth in the lab. And what I decided to do is summary. So let's say that someone, technically didn't go through everything, will be like, these are the high points to keep in mind. And now we're going to dive into the lab. So there'll be a little bit of didactic at the beginning, but really it would be essential, because by the way, the course is 27 hours. So it's a lot of information. And some of it will be repeat because I show some lab stuff, but you know how it is when you're actually hands-on, it's so much better just to learn and to be exposed to that and ask questions and that sort of thing. So yeah, so right now it's set up, and we're going to see, I might not like that after I've done it this way, but I'm trying to do it where we do hybrid, where it's online. You take it at Pelvic Global Academy, and then you take the online part, but then you also have the hands-on.
That's awesome. So we can find the course at Pelvic Global Academy. If you're a health professional or a fitness professional, there's the GFAM, Global Pelvic Health membership.
Alliance, you got it.
Alliance membership, yeah.
Membership, yes.
I always forget what the A is, Tracy. Alliance membership.
It was fancy. We added that in.
And can you tell us where we can find you on social media? You're very approachable. We've always had such a great working relationship. You've hosted my courses. I would love to host you here in Australia. It would be awesome to continue with that. And if people want to reach out to you, what's the best way to get in touch with you?
Yeah, I'm on Instagram at Pelvic Guru 1, the number 1. And that's probably the best way. You can message me or just follow me there. That's the way I really do interact. And I do, I'm so passionate at this point. I've got this great academy running. We've got the membership running. My goal is just to try to educate as many people as we can on all sorts of topics. That's just been a really big passion of mine. So follow me there at Pelvic Guru 1 and interact with me there. Feel free to join our membership. We'd love to have you. And we also do have a free group called right now it's Pelvic Guru Academy. Everything's changing to Pelvic Global. because we're getting fancier with, we're getting global. So we're changing it, but it is Pelvic Guru Academy. There's a free Facebook group as well that you can join to ask questions and interact there. And I do have an email that I may give out at some point. But yeah, Pelvic Guru One at Instagram would be the easiest way.
Awesome. Thank you very much for coming on the podcast. It's such an informative podcast. Really appreciate your time, your expertise, and just simplifying something that can be quite a lot of decision branches, and like you said, just working through those differentials, being systematic about it all, mindful of the anatomy. It's been a great episode, and appreciate it.
Thank you. I think if I can also just impart one other thing is that even though it sounds overwhelming, so if you're listening to this, you're thinking, oh, I can't, there's just so much I don't know, or patients are like, where do I go to find these kinds of people? I think the biggest thing is there is hope for those treating this. There's ways to continue to learn that you can help more patients. And for patients on the patient side, there's so much hope that they can still find, if they can get to the right people, that there is hope for them. And I'm sorry that it's so hard. It really is hard in the world of pelvic pain to get the right specialists. It just really is, but there is hope for it. And just know that there are people that really are trying to find you and are trying to help you. And the more that we can train people, the more that can happen. So.
Yeah. That's awesome. Thank you so much, Tracy.
Yeah, you're welcome. It was a pleasure. This was really fun.
Well, that's it for this episode. Be sure to hit like if you enjoyed the episode and leave any comments or questions below. We'd really like to hear from you.
If you haven't already hit subscribe, please do so now so that you can be kept notified when we release our next episode.
Otherwise, thank you for listening, and we look forward to having you back with us for another episode of the Women's Health Podcast.